This is the University of Otago.
Good evening, everyone. On behalf of the University of Otago, I would like to warmly welcome you to this inaugural professorial lecture. This is the time, as you know, during the week when we all take time out of our busy lives and simply take an opportunity to listen and to learn. As usual, it's fantastic to see so many of our staff and our students here, as well as members of the general public. I'd like to extend a particularly warm welcome to a number of people who are in the audience this evening, including Professor Crump's wife and their fourth and brand new 2-week-old baby, which I've not yet spotted, but I suspect we might hear from at some point during the rest of this evening's proceedings. And also his parents, who have traveled here from Marlborough to be with him this evening. And I'd also like to extend a very warm welcome to Stuart and Marilyn McKinley, who have made the McKinley Chair in Global Health possible. This evening, we're all here to benefit from the wisdom of Professor Crump and to celebrate in his success. Now, when it comes to academic staff here at the University of Otago, our goal is always to recruit the best and the brightest from New Zealand and around the world. And every once in a while, we can actually do both at the same time. John Crump is actually a native Kiwi. He was educated here at the University of Otago. But he has also traveled and worked extensively around the world. But fortunately for us, after all that travel, he's decided that there's no place like home. So we feel extremely privileged to have the opportunity to welcome John back to Otago, a privilege that was actually made possible by the McKinleys. Now, I've had the chance to take a sneak peek at John's slides for this evening. Not many professors actually run them by me before they present them, but I did take the opportunity to look at them, and I think that we are all in for a treat. John's research is a very clear and poignant example of the way in which Otago academics use their expertise to increase human health around the world. Now, from time to time, I'm sure everyone in this audience has complained about our healthcare system in New Zealand, but I'm pretty sure, if nothing else, you will leave tonight feeling extraordinarily lucky. In closing, I am very proud once again to call Professor John Crump one of our own. John, welcome back, and congratulations on your well-earned chair. And I will now call on Professor Barry Taylor, the Dean of the Dunedin School of Medicine, to tell us a bit more about John's journey to becoming the McKinley Professor of Global Health.
Thank you. This is always a fascinating thing when you come to introduce somebody and then you try and find out what they're really like. So apart from reading his CV and talking to him directly, I've tried to and understand I guess the journey that he's gone to get there, and some of it's dry, but the majority of it is not. So the dry stuff is MBCHB 1993, FRACP or Fellowship of the Royal College of Physicians in 1997. A similar fellowship in pathology, which is quite unusual and actually really important, in 2004. And an MD submitted and awarded in 2013. And as Harleen has mentioned, a basic University of Otago degree, during which I note that one of the features of our medical training is an elective period, usually for 3 months, and that in fact he took his elective in Kenya, and that will probably become relevant as we go through. He finished his degree, did his house surgeon year in Christchurch, then went to London and worked at the London School of Hygiene and Tropical Medicine, and during that did his first research fellow job actually in South Africa, and I guess got his second taste of international health work at that stage. Came back to Christchurch as a registrar, then Canberra as an infectious disease registrar, and then went to Duke University in the USA, where he continued on with the infectious disease theme, and then after a year there, joined the CDC as the Epidemic Intelligence Officer. Now, what a wonderful name. I like that. And talking to him, I realized that, in fact, it was an exciting thing. Single at this stage, able to go all over the world. And, in fact, the CDC is well known for assisting all countries of the world that actually have epidemics evolving, and a critically important organization for the world. So in that role, he indeed worked on one of the most famous modern episodes around the anthrax scare, which many of you will still remember. And in fact, I note that he received a Distinguished Service Award because of the work that he actually did as part of that anthrax investigation. There's some stories to tell, which I don't think, which will have to be after tonight, because he's not going to talk about that at this particular lecture. So now he sits as the McKinley Professor of Global Health and co-director of the Centre for International Health at the University of Otago. I should really acknowledge, again, Stuart and Marilyn McKinley for endowing that chair. Thank you very much. You'll see, I think, how important it is. But it's not his only role. He also has got an appointment as Adjunct Professor of Medicine, Pathology and Global Health at Duke University, and continues that association. And perhaps even more important, continues as a formal medical epidemiologist with the CDC in the States. He has 121 refereed publications and 2 book chapters. And this man, as far as I can tell, has lived and worked in Africa, mainly Tanzania, but also Kenya, Myanmar, Egypt, Asia, and Central Africa. He's an infectious disease expert, especially dealing with infection in low-resource countries. His topic is fascinating to me. I spent some time in Africa not very long ago and saw the real human tragedy that, in fact, he's going to talk about in the rest of this lecture. So thank you very much.
All right, good evening. I'd like to start by thanking you for coming along, and of course the university for the opportunity to deliver this lecture. I also echo the thanks to the McKinleys for the support for my position, without which I wouldn't be here. It's both a delight and a challenge to explain my area of interest to a broad audience. My young children, who I'll say are under 6 and under, I think understand my work as flying on jets and playing on my computer. And this evening, I've added dressing up like a guy from the Middle Ages. So I hope I do a better job of explaining myself to you than perhaps I have to my children. I'm going to be talking about fever in the tropics, an interesting prospect during a week when the weather here has reminded us we're 1 degree latitude closer to the South Pole than the equator. But I hope it at least transports you somewhere else for a while. So a patient with fever poses a diagnostic challenge anywhere in the world, but especially in the tropics, where fever is one of the most common reasons for seeking healthcare. This patient's been admitted to a district hospital in an African country, and the temperature chart shows that she's had fever for several days. The challenge arises because fever is a symptom of many infections and even some non-infectious diseases, and they're difficult to distinguish from one another just by taking a history and examining the patient. Without knowing the cause of fever, we don't know best how to treat her. And in low-resource areas, the problem's compounded by the limited number of healthcare workers, extremely high patient volumes, and few diagnostic laboratory services. By way of contrast, though, this patient's problem does not pose a diagnostic challenge. This man from a forested region of Gabon has a worm migrating underneath the outer layer of his eye. This can really only be one infection. It's lower, a worm that infects soft tissues and bloodstream of people living in affected areas following the bite of a mango fly. By contrast with the patient with fever in the previous slide, this presentation of loiasis is a diagnosis that can be made with a high degree of certainty on the spot, with limited training and limited laboratory support. Now, the history of fever in medicine is very ancient, and I don't plan to start at the beginning. Instead, since we're discussing fever in the tropics, I thought I'd pick up the story with this gentleman. You might recognise him. This is David Livingstone, who was born in 1813 in Blantyre, Scotland. The bicentenary of his birth was marked last year. As you'll know, Livingstone spent from 1841 until his death in 1873 in the interior of Central and Southern Africa. He explored the Zambezi River and its tributaries, and he died in present-day Zambia with fever and dysentery after joining the effort to discover the source of the Nile. He was a keen observer of many things, and he kept detailed records both of his own health and the health of his colleagues and workers. His observations are relevant to the understanding of fever and its causes 150 years ago, and it's worth looking at the Western view of fever at that time to highlight what's changed since. So I'll just entertain you with a bit of history for a minute. This caricature etched by Rowlandson from 1792 shows ague, the rigor or shaking chill, as a snake wrapped around the patient who's trying to warm himself in front of the fire, alongside fever, a furry monster conveyed by the feeling of hot. At this time, fever was largely considered to be a single disease, to the extent being referred to, including by Livingstone, as the fever, although some further subclassified the fever based on patient exposures, the pattern of fever, and other symptoms and signs. Notably, at this time, the fever was not understood to be caused by germs, but by a range of patient and environmental factors. This conception of fever had its roots in the Greek view from the time of Hippocrates and Galen, that diseases have natural causes, but also from earlier ideas of fever as a punishment meted by angry gods and retribution for bad behaviour. In his writings, Livingstone frequently identifies diet and moral factors like active exercise and hard work, fresh air and cooler climates as protective against the fever, but he also identifies that bad air, such as found in marshy environments and hot climates, was responsible for causing fever. This concept of disease being caused by noxious air was called the miasma theory. So we can boil down Livingstone's conception of fever as a single disease caused by environmental miasma or bad air, with risk being modulated by host or patient factors like hard work and exercise. To put this, Livingstone's writings at the time in context, in 1858, the same year that Livingstone embarked on his Zambezi expedition, London was experiencing the so-called Great Stink, when human waste contaminating the Thames River produced a strong and pervasive feculent smell. Epidemics of fever illness like typhoid, which essentially means fever with mental clouding and abdominal symptoms, and the diarrheal disease cholera, which were both rife in London at the time, were attributed to exposure to noxious air or miasma. Everyone could smell it. This caricature from Punch magazine parodies the polymath Michael Faraday's initially futile efforts to petition the British Parliament to clean up the Thames River to prevent fever and diarrheal disease. And crossing to Africa, more or less just a few years later, this sketch shows Livingstone exploring the Zambezi River a few years after the Great Stink in London. As I told you, Livingstone was well aware of the dangers of idleness. And he's being carried here not because he's lazy, but because he's suffering from one of the many bouts of the fever that he was to experience in his lifetime. And this night he wrote in his diary, "The mangrove swamps emitted a most offensive smell and gave us the impression that they were most fitly named the hotbeds of fever." So he understood that these marshy environments were dangerous. Of interest, Livingstone was an early user of quinine, a chemical extracted from the Peruvian cinchona tree bark to treat fevers. And here are some quinine-containing chill and fever tonic labels from the 19th century. They again illustrate how closely swamps and marshy environments were associated with fever. And of course, today quinine in higher concentrations is known as an effective anti-malarial drug. and persists as an ingredient in tonic water. Indeed, the potion on the left also contained 10% alcohol, so it was not too far from what we would call gin and tonic today. I'm not sure if you've thought about it, but the word malaria is actually deeply rooted in the miasmatic theory of disease. And the word dates from approximately 1740 from the Italian mala for bad and aria for air. Thus, malaria became the term for fever caused by foul air from marshy districts. However, this view of causation of fever began to change quickly during the 19th century, as the idea that contagious seed-like entities were responsible for the transmission of infection. And this gained increasingly widening acceptance. The idea is known as the germ theory of disease. In 1880, the parasites that cause malaria were discovered by Charles Laveran, shown here. And in 1897, mosquitoes were identified as the vector of malaria by Sir Ronald Ross, shown on your right. Each won a Nobel Prize in physiology or medicine for their work, and such discoveries were repeated for many infectious diseases, and these discoveries underpin our current understanding of causation of infection. So, whereas Livingstone saw fever as a single disease caused by environmental and host factors, the current Western view of fever looks something like this. We now understand that fever is one of several signs of a disease state that we call infection. We understand that infections are caused by germs or pathogens that infect hosts and that may interact with the environment. To continue with the malaria story, the infection malaria is caused chiefly by a parasitic pathogen called Plasmodium falciparum, transmitted by Anopheline mosquitoes that breed in marshy environments in the tropics. Hosts or patients who lack immunity from past exposure are susceptible to disease, developing a range of symptoms and signs of malaria, including but not limited to fever. So although it's interesting that although Livingstone didn't know that malaria was caused by a parasitic germ that was transmitted by mosquitoes, he quite correctly believed that exposure to marshy environments in the tropics increased risk for disease. Quite remarkable, really, I think. So among Livingstone's broad legacies, which I'm not going to go into in detail, included the opening of Central Africa to a range of Western colonial influences. Among these were international trade, Western education, and relevant to this talk, Western healthcare. The history of Western medicine in Africa that followed is often divided into colonial and post-colonial periods. During the colonial period, the focus was primarily on the health of European expatriates living in the tropics. It was during this period that the discipline of tropical medicine really got its start, with fever as its most fundamental problem. In parallel with the scramble for Africa, there was a so-called scramble for African diseases, during which time a number of so-called great men of tropical medicine were widely celebrated for discoveries fundamental to our current understanding of infectious diseases. Over time, tropical medicine expanded its scope to the health of indigenous peoples. Diseases preventing and development needed to be understood and controlled to grow productivity in the burgeoning colonies. So in a way, it's a discipline with a somewhat selfish origin. Moving to the post-colonial period, developments included efforts to extend primary healthcare services beyond cities and tropical areas to rural parts of countries, adoption of pragmatic so-called syndromic approaches to patient management that can be used by healthcare workers with little training to evaluate and manage high volumes of patients. And interestingly, a de-emphasis of laboratory and pathology services. This is a typical outpatient clinic waiting area at an African healthcare facility today. Patients are many, healthcare workers are few and may have quite limited training, and laboratory services are minimal or non-existent. In such low resource settings, something called syndrome-based clinical management is often used. This slide shows the covers of World Health Organization's syndrome-based management guidelines. They're called Integrated Management of Childhood Illness and Integrated Management of Adolescent and Adult Illness. By following these documents, healthcare workers can triage and classify sick patients into various clinical syndrome categories like fever and find suggestions for appropriate treatments. For example, a child with cough who has difficulty breathing and is found to have fast breathing would be classified as having pneumonia, and the guideline would recommend an antibiotic called amoxicillin for 5 days. So what are some of the common conditions that healthcare workers are faced with in the tropics? It turns out that diarrhea, cough, and our friend fever are among the most common problems. This slide shows the occurrence of diarrhea, cough, and fever among more than 1 million surveyed children aged less than 5 years in low and middle income countries from 1986 through 2012. This analysis was done by my postgraduate student, Nimrata Prasad, who might be here. And fever, shown in red, is actually the most common symptom, being reported for more than a quarter of children over the 2-week period that was asked about in this survey. As you can see, fever often occurs with cough or diarrhea, but in any given 2-week period, about 7% of children have isolated fever without other features. And this brings us back to the diagnostic challenge. Fever has many causes. Some are life-threatening and others are self-limiting. And most can't be distinguished from one another by taking a history or examining the patient. In settings with few healthcare workers, large volumes of patients, short patient consultations, limited laboratory services, there's little chance of making an accurate diagnosis. So what's causing this patient's fever and how should she be managed in a low-resource area? Well, the World Health Organization guidelines for the treatment of malaria from 2006 have this to say: the signs and symptoms of malaria are nonspecific. Malaria is clinically diagnosed mostly on the basis of fever or a history of fever. This recommendation could be paraphrased as fever in the tropics should be assumed to be malaria and treated as such. However, we know that the role of malaria as a cause of fever has actually changed considerably over time in the tropics. So progress with malaria control could be dated to all kinds of years, but I chose 1874, which was the year that the chemical DDT was synthesized. In 1939, the insecticidal property of DDT was discovered. Then in 1934, the drug chloroquine was discovered, and by 1946, it had been established as a safe and effective anti-malarial. Using these tools in 1955, the global effort to eradicate malaria was launched. Residual insecticides, anti-malarial drug treatment, and surveillance for malaria were used with the aim of actually eradicating the disease. While these efforts were successful in temperate zones and in areas with seasonal malaria, eradication was not attempted in much of malaria's homeland in sub-Saharan Africa. However, 1998 saw the return of optimism and a scale-up of malaria control efforts using more contemporary tools. Indoor residual insecticide spraying was used, but this time accompanied by insecticide-treated bed nets, something that children sleep under at night to protect them from mosquito bites. Newly developed malaria rapid diagnostic tests that don't require sophisticated laboratories were used to guide treatment with more effective antimalarials called artemisinin-based combination therapies. And this time, unlike the 1955 effort, there was considerable focus in sub-Saharan Africa and with some substantial success. This graph shows estimates of global malaria deaths by age and geographic region between 1980 and 2010. As you can see, malaria deaths are thought to have been declining in all regions and all age groups, including in Africa, since around 2004, in part due to the control efforts that I just described. One effect of the malaria decline is that the proportion of patients with fever who actually have malaria has declined markedly over the past decade. In addition to this change over time, malaria varies considerably in space as well. This heat map shows the proportion of people with malaria in Africa from 2010 from community surveys that test for the main malaria parasite, Plasmodium falciparum. Areas in grey are essentially malaria-free. Areas in red, the proportion of the population carrying malaria parasites approaches 70% in the community, whereas parasite rates approach 0 in areas in blue. The main message here is that the role of malaria as a cause of fever illness is highly heterogeneous and in fact absent or uncommon in large swathes. This means that malaria is a more common cause of fever in some areas of Africa or the tropics than in others. So given this context, what happens if all fever is assumed to be due to malaria? Well, this slide summarizes the results of a study of severely ill patients hospitalized with fever in northern Tanzania. My long-term collaborator, Hugh Rayburn, and others studied more than 17,000 hospital admissions in northern Tanzania. Of these, 4,500 met study criteria for severe fever illness and had malaria film results confirmed at a reference laboratory. Of these patients, about 46% had laboratory tests positive for malaria, and the other half were negative for malaria. It's notable that 95% of all patients were treated with intravenous quinine for severe malaria, despite more than half having negative malaria films. Furthermore, of those without malaria, only about 2/3 received an antibiotic treatment for common but potentially fatal non-malarial bacterial infections. Not surprisingly then, patients admitted to hospital with fever and malaria on your left had a better chance of surviving than those admitted with fever due to something other than malaria on your right, 7% case fatality ratio versus 12% respectively. The problem of malaria overdiagnosis among patients with fever in sub-Saharan Africa and the finding of higher case fatality ratios among febrile patients without malaria compared to those with malaria has now been confirmed by many other studies. So in 2010, the World Health Organization responded to the concern of malaria overdiagnosis by changing the guideline for the treatment of malaria. WHO now recommends that antimalarials be prescribed based on the result of a malaria diagnostic test, rather than on the basis of the presence of fever alone. And to quote this document, prompt parasitological confirmation by microscopy or malaria rapid diagnostic test is recommended in all patients suspected of malaria before treatment is started. And treatment solely on the basis of clinical suspicion should only be considered when parasitological diagnosis is not accessible. But this new guideline and guidance immediately raised new problems for healthcare workers. What to do with the patient with fever and a negative malaria diagnostic test, particularly the patient who's severely ill? When tests for malaria were rolled out, it was quickly found that in many places, the vast majority of patients with fever did not in fact have malaria at all. For the few patients with a positive test, the way forward was clear: prescribe an antimalarial. But for the vast majority with a negative test for malaria, healthcare workers without a laboratory are really stuck knowing what to do. Without a picture of what the major causes of severe illness with fever are, it's very difficult to know. And this question underlies much of my own research, which I'm not going to spend too much time on, but I'll tell you a bit about. Okay, so this is Kilimanjaro Christian Medical Center in Moshi, Tanzania. It's one of Tanzania's 4 consultant referral hospitals, so it's quite high up the hospital hierarchy. I was privileged to be based here for 10 years and continue to do a lot of work here with Tanzanian collaborators at this institution. and that's Mount Kilimanjaro in the background. We were interested to understand the causes of fever among patients admitted to this hospital in Moshi. You might be wondering what the malaria situation in Tanzania is like. And as with the earlier heat map that showed the whole of Africa, this map shows the proportion of people with malaria in Tanzania in 2010 from community surveys that test for the main malaria parasite. Again, areas in grey are essentially malaria-free, and areas in red, the proportion of the population carrying malaria parasites approaches 70%. As you can see, in Moshi is located in an area of very low malaria transmission intensity, straddling areas in blue and grey, and the grey area, of course, being Mount Kilimanjaro itself, which is so high that malaria transmission is unlikely. So we wouldn't expect malaria to be a common cause of fever here. We looked at healthcare worker admission clinical diagnosis versus high-quality laboratory diagnosis of patients with fever admitted to hospital in northern Tanzania. We carefully studied 870 hospital admissions using diagnostic methods at national and international reference laboratories. We found that healthcare workers clinically diagnosed and treated almost 2/3 of admissions with fever as malaria, shown in red. But using the best possible laboratory diagnostics, only 1.6% of the patients actually had malaria, in red on your left. Right, should I say. And about half of the fever patients were confirmed to have the infections listed here. Notably, healthcare workers never considered or diagnosed most of these non-malaria infections, and many had not heard of several of them. Now, I'm not going to go into a great detail about these non-malaria infections, which are fascinating to an infectious disease physician, but probably not to many others. But I will say that many of these have effective and potentially life-saving treatments. And a large proportion, including brucellosis, leptospirosis, and Q fever, are transmitted to people from livestock, rodents, and other animals. And these infections also have important impacts on the survival, growth, and reproductive success of economically important livestock species in Tanzania. These so-called zoonotic infections are the subject of some of my ongoing collaborative research in Tanzania. Here we see my field team sampling livestock and testing owners for zoonotic infections in a pastoralist community in northern Tanzania, in this case a Maasai community. This type of work requires close collaboration between human and animal health experts, an approach that's often referred to as One Health. Okay, so we've so far mostly discussed illness due to infections that cause fever, but we should not forget death. Here, during the Great Stink of 1858, the allegorical figure of death rose on the polluted Thames River as miasmatic air hangs thickly and dead animals float by. I don't know if you've thought about your final contribution to the health system, but unless you're an organ donor or you donate your body to science, your last effort is likely to be a piece of data called your cause of death, or what you died with. It's worth noting that most people in the world cannot, in fact, make this contribution. This is because of inadequate vital event registration systems and lack of the sorts of laboratory and pathology services that allow us to assign cause of death in a country like New Zealand. There's a saying in the study of disease in populations that the uncounted count for nothing. And this sounds very harsh, but let me explain what I mean. This slide shows how we use evidence like aggregate data on cause of death to improve health. It all starts with measuring what causes illness and death in a country or region to figure out what the big killers are. We then seek to understand the risk factors for these major causes of illness and death, and where possible, design interventions to address these risk factors. These may be adopted into national policies, allocated resources, and implemented. And we track the success of these interventions by looking at impacts on illness and death. And so the cycle continues. For example, if we find that lung cancer is a common cause of death and that smoking is a major risk factor, tobacco control interventions can be designed, adopted into policies and implemented, and then impacts on illness and death evaluated. And so the cycle goes on. Yet the cause of death is not recorded for 2/3 of the world's population who live in countries that lack reliable systems for issuing medical death certificates. And these happen to be the same countries where the majority of premature global deaths occur, including those due to infectious diseases that present with fever as the chief complaint. To understand cause of death in such settings, focused studies are done using a method called verbal autopsy. Here, workers assign probable cause of death based on interview of families about the symptoms of the deceased leading up to the time of their death. And you guessed it, the verbal autopsy scheme classifies a death with fever in a malaria endemic country as a malaria death. Based on what I've told you so far, you'll recognise that the potential for misclassification here is huge. If a healthcare worker cannot reliably distinguish malaria from infections other than malaria during life, it's unlikely that a village healthcare worker will do better by interviewing family members sometime after their relative has died. And the global health community is realising that many global deaths attributed to malaria by the verbal autopsy method are probably not due to malaria at all. Here's a prestigious magazine called Nature. Verbal autopsy methods questioned. Controversy flares over malaria mortality levels in India. The obvious concern here is that if the uncounted count for nothing, then the incorrectly counted focus attention and resources on the wrong diseases. So perhaps that's a good point to make some closing comments. You might have wondered why should universities or the University of Otago specifically be involved in global health? Well, I hope I've shown you that for people living in low resource areas, lack of health information directly fuels illness and death. Through partnership, universities can do collaborative research that has immediate impacts on health. And by strategic selection of postgraduate students from low resource areas, we can work together to help develop researchers who will answer pressing health research questions in their home countries. For universities in wealthier countries, global health is an activity not owned by a single discipline within or even outside the health sciences. And I hope that I've shown you with the example of both human and animal health experts tackling zoonotic infections in Tanzania, that global health is fundamentally a multidisciplinary activity where people from a wide range of specific skill areas are brought together to apply their skills to solve problems. And in this day and age when cross-disciplinary work is increasingly expected by funders and sought by institutions, the practice of global health provides an obvious platform for getting people within and between institutions and indeed between countries to work more closely together. I'd like to finish by returning to the history of fever on a slightly more personal note. This paper is by my namesake and great-grandfather, Reverend John Crump. He was an English-born New Zealand Methodist missionary in New Britain, an island that was then part of German New Guinea, shown here. Although he wasn't a physician, he took a great interest in medical matters. Among other things, he made early observations on the indigenous surgical practice of trephining following skull fracture. Fortunately, his paper, shown here, has been cited only 6 times in the 113 years since it was published. So he did not set me an insurmountable academic precedent. Although, as you can see, he did outdo me when it came to facial hair. He worked in the tropics during that golden age of discovery in tropical medicine, when the miasma theory gave way to germ theory and fever became at once better understood and yet indefinitely more complex. His diaries describe many episodes of fever attributed to malaria among family members and others. And I've often wondered how many were actually malaria and how many were something else. We'll never know, but it's striking how little we still know about causes of fever beyond malaria in the tropics more than a century later. So thank you for your attention.
Hello, my name's Rob McGee and I'm acting head of the Department of Preventive and Social Medicine and it's my very pleasant task to say a few words after John's talk. And I think the first thing I'd like to say is to thank John for what I found a very enjoyable and engaging talk. And I think I especially I'm the sort of person who likes history as a background to research, and I really enjoyed John setting that historical context to the work on fever and how that informed the work you're doing. And I think, John, so I don't really want to add anything about that, but I think I did want to take up the personal history that you introduced at the very end, and because I was fascinated by that journal and that work. And I thought, well, six citations is not very much. I should go and find out a little bit more about this. So, in fact, I looked up the Journal of the Royal Institute of Anthropology, and it has an impact factor currently of 1. So if you have 6 citations and an impact factor of 1, nowadays the head of department would be kind of descend upon you to try and work out how you might increase your productivity and your research quality. But in fact, if you can actually find the paper, which I went and found, and it's fascinating. If you look at the people who are publishing in that journal at the time, and the fellows of the Royal Institute, they included, the names that stood out to me were Francis Galton, who's an anthropologist who also is the founder of psychometric theory, James Fraser, who I studied many years ago in sociology, who was the founder of comparative study of religions, and William Rivers, who was also studied kinship relations in Torres Strait and also did work on treatment of shell shock and subject of various documentaries and books. So I think actually that's pretty good company for someone to be publishing in. So I think you probably want to be not too hard on the quality of that publication. And it does also suggest that maybe just citations and impact factors don't quite capture the quality of our work sometimes. But the other thing I would like to say is John recently was awarded a prize from the Dunedin School of Medicine for the quality of one of his publications, which was terrific too. And I think finally, the last thing I'd like to say is just to thank John for his contribution to our department through his terrific work with the Centre for International Health.